everyone. Good afternoon. You've joined the monthly Penguin webinar for our AIM Perinatal Mental Health Bundle series. My name is Kaylee Vitek, and I'm the Penguin Project Manager for our OB initiatives. We have a really wonderful team presentation on deck for you today, focused around provider education for perinatal mental health. So we'll have the team presentation from BMC Brighton and then a Pearl on the free ACOG eModules that are available for additional education. So let's get started. So again, welcome. Please type your name and institution into the chat so that we can keep track of attendance. Our optional fun share for this month is feel free to share with the group your favorite summer food. Yesterday was so beautiful, and me and my family had a great cookout with all the usual hot dogs, hamburgers, corn, watermelon, and all that good stuff. So really enjoying the summer weather and food lately. Please mute yourselves when not speaking and feel free to type your questions into the chat. We'll have time to answer those at the end of the webinar. And as always, these webinars are recorded and we'll upload that recording with slides to our website soon after. So I mentioned our agenda a little bit earlier, so I'll keep going into announcements. As always, we want to thank and acknowledge our Mental Health Bundle work group for helping put on these webinars. And of course, acknowledge the teams participating in this bundle and sharing on the webinars. We have a really wonderful group. Just a quick reminder about our participation checklist. I hope everyone is familiar at this point with our participation requirements, but the one I wanted to flag is we'll be doing another implementation feedback survey in August. So you might remember completing that survey this past spring. We just asked about, ease of completing participation requirements and kind of several other questions related to implementing the bundle. Your responses were extremely helpful for informing some of our webinars that we'll be having coming up, as well as just other resources that we can improve upon and put out there for you all as you continue implementing this bundle. So please keep an eye out for that survey in a couple of months. We want to give a big thank you to the 280 plus people who came to the Spring Summit on May 22nd. It was a terrific program. We've gotten overwhelmingly positive feedback. And I do want to give a special shout out to 2 Penguin teams who won awards for their perinatal mental health work. So shout out to the Tufts Medicine Lowell General Hospital perinatal mental health team, as well as the Boston Medical Center OB-GYN Integrated Behavioral Health Program team. These teams are doing incredible work, and we were so thrilled to honor them at the summit and support their continued efforts in this space. So slides and materials from the summit are coming soon to our website, so keep an eye out for that if you wanted to check out one of the presentations again. And then the evaluation to be completed for continuing education or certificate of attendance expires on June 30th, so please do complete that if you haven't already. And as always, I'll send out any relevant links in my follow-up email, so don't feel like you have to scramble for a QR code this time. Reminder that we do have our Perinatal Mental Health Bundle Toolkit up on our website. This has so much information that you can use to help implement the bundle and was really generously worked on with us by our Mental Health Bundle work group. The toolkit itself is kind of in set versions, but we do have a specific page on the website for community resources that is updated more regularly. So check that out when you can for new resources. So in Massachusetts, a few things to note. The Blue Cross Blue Shield of Mass Foundation has a call for proposals for their Perinatal Health Initiative program. This program will provide between $30,000 and $60,000 a year for 2 years in 3 award categories: community education and support, policy and advocacy, and build, support, and sustain a perinatal care team. So if you are in need of any grant funding, these applications are due July 8th at noon. There's another opportunity to support funding the Moms Matter Act that the Mind the Gap Coalition in Massachusetts has been working really hard on for the last few years. And so this is an opportunity to secure their place in fiscal year 26 state budget. So there is a link to an action alert that you can add your name to in support of this work. So the Massachusetts AWHONN 2026 conference is coming up October 16th and 17th. It'll be at the Seacrest Beach Hotel in Falmouth, and there will be a pre-con training on the safe use of intermittent auscultation on the 16th in the afternoon. The pricing options for members and non-members are listed here, as well as the QR codes to register for the conference and book a hotel in the room block. This is a standing announcement, standing offer from MCPAP for moms to come to your institution and provide training or grand rounds. This is a really wonderful resource that we have in our state, so please take advantage of it in your work for this bundle. If you're interested in learning more or would like to schedule time with MCPAP, you can email Beth McGinn at her email here. We've also elevated that the MGH Center for Women's Mental Health has a podcast that is now starting, and you can listen and subscribe to it wherever you get your podcasts. This is a wonderful resource to hear answers to questions from parents about mental health and consult with experts. So this is a really great project that they're just beginning. And finally, the team at UMass Chan conducting a PCORI grant to implement and compare approaches for integrating OB and mental health care in the practice setting are still recruiting. So if your practice is interested in receiving funding for this, please do reach out to Dr. Nancy Byatt. All right, a few national announcements before I turn it over to the BMC Brighton team. So wanted to let everyone know that this Friday at 2, the National AIM program is hosting a webinar as part of their sustainability community of learning around sustaining the gains amidst policy changes in the healthcare landscape. So the speakers on this will be discussing strategies for how to respond to policy or guideline changes that may affect your care delivery, and also talk about best practices for communicating new changes for project sustainability. So we've mentioned sustainability a few times here on this webinar series. We'll be coming back to it again in the fall with some presentations and resources, but this is a really good time to start thinking about how you might sustain the work that you've done so far on this bundle. And AIM is a really great resource for that. I know the National AWHONN Conference is coming up later this week. Just the last call to let you know about a teen birth pre-con that is happening on June 21st. So if you'll be at the AWHONN conference and are interested in brushing up on your teen birth principles or thinking of maybe implementing it in your institution, this would be a great time to connect with the teen birth team. NICHQ has a webinar coming up on June 26th on safe sleep. Just a really good refresher on a very important initiative and practice and information to share with parents. So do tune into that. And finally, we wanted to bring to your attention that ACOG has released some updated advisories on vaccination and management for OB/GYN patients during a measles outbreak. So the full advisory is available on their website. All right, thanks for sticking with me through announcements, and now I will turn it over to Lisa.
Well, thank you so much for this opportunity to present today. I also just want to start by saying thank you to this network. As you'll see during the presentation, we have learned so much from the other hospitals in this collaborative. So we are Boston Medical Center in Brighton. Next, thank you. So I put this in just because we have an interesting history that actually goes back to the late 1800s in Dorchester, with what started in as a home for infants that then became a um, birthing center and evolved into St. Margaret's Hospital, which was a staple of Dorchester for years and years. And in fact, many of the people who work at St. Elizabeth's were delivered at St. Margaret's Hospital. In 1993, they moved the maternity service from St. Margaret's to St. Elizabeth's Medical Center, where we are now. There was a period of time when we were owned by Steward, which people may have heard about, and now we're very excited to be part of Boston Medical Center. So our new name is Boston Medical Brighton. But we are very proud of the tradition of serving this community. Next. Thank you. So our birthing center here has 11 LDRs, 2 ORs, and 15 postpartum rooms. We have a 15-bed NICU, and we have a robust MFM service. We are a teaching hospital. We have BU and Tufts medical students rotating with us, and we also have our own residency programs here in anesthesia, internal medicine, surgical specialties, as well as psychiatry, which offers us a nice opportunity. The community that we serve is diverse, with people from all over the world. We're especially interesting, I find, is that we have a large Russian community historically. And so we see a fair number of immigrants from Ukraine, Kazakhstan, and other former Soviet republics, as well as from South America, Central America, and of course, Haiti. Our split in terms of public and private insurance is about 40-60, with 40 private, 60 public insurance. And then our team leaders, I want to acknowledge Dr. Raquel B., as we call her, who's our OB lead, Cara LeBlanc, who's our professional develop RN, and Hannah Fish, who's our social worker representing the outpatient side of things. But we've actually have a really lovely team with Jennifer Andrade, who's a nurse practitioner, Rita, who's our practice manager for OB, myself from PEDS. We had a wonderful social work student, Anna, who did a lot of work for us. And then Connie Shulkin O'Brien, who was really the leader for getting us started on this project, and was the director for maternal health services here, but then retired a little while ago. And then we had 2 wonderful staff nurses who have helped us with this project as well, Colleen and Elizabeth. Next, please. So we started actually in spring of 2024 as part of the mini collaborative. And so our team then we actually had a relatively small team at that point, with Karen Franklin from OB and Katie Mata from OB helping to lead the project. And we decided that we wanted to focus on trauma-informed care training, partly because we had felt from our staff that there was a desire for that training, given the patient populations that we were seeing. We were often feeling like we needed a little more training to better meet their needs, and partly because there were some opportunities. In addition to the staff interest, it so happened that as part of Nurse Appreciation Week that year, they were going to be doing a lecture on trauma-informed care. And coming from Tufts, I was lucky enough to have been involved with a trauma-informed care initiative there. And the doctors that I worked with there, Reed and Danielle and Jean, were kind enough to say that we could take some of the materials that they had developed and bring that over for our training. So you can see there an example of one of the educational sheets that they had created for training staff at Tufts. Next, please. So this was our driver diagram. And so our goal was that by August 1st of 2024, that 70% of our mother-baby unit staff, so we were focusing on just one unit, would complete formal training in trauma-informed care. As we thought about the drivers, we thought, well, we'll need to get the training materials. We'll need some kind of trainers or content experts to help us with the education. We need to have a system for data collection to know how we were doing in terms of meeting this goal. And then it would also be key to have staff engagement as well. And so we looked to see what we already had in-house in terms of at St. Elizabeth's, thinking about connecting with the Department of Psychiatry, for example, our social workers. And we also reached out to see through this network what other resources we might have available. So for example, when we looked at where we would get the training materials and the trainers, we did connect with IHR, the Institute for Health Recovery, to see if it would be possible for them to do some training with us. Next slide, please. Okay. So we started by doing a pre-survey to find out our staff's knowledge and comfort level of trauma-informed care. And what we found was that most of our staff had not had any formal training in trauma-informed care, but were definitely interested in learning about it. Laura Sternberger from IHR was kind enough to come and do a consultation for us to talk with us about what our needs were, what IHR could offer us, which is a wonderful program of both didactic and in-person small group training. We were very excited about this. It does cost some money to do it. And we were approved for it by our CNO, and then Steward went bankrupt. And so we did not have the money. So we were not able to pursue that option. But it's a wonderful, wonderful group. We did have the nursing lecture on TIC in May that was part of a symposium for Nurse Appreciation Week. And then we were also lucky enough to have Dr. Reed Mergler, who is a specialist. She's a psychiatrist with a special interest in perinatal mental health, came and gave a grand rounds for us that was well attended. And we surveyed people after these events, and they did report an increased knowledge and confidence in applying TIC principles, and also asked for more training or for some small group training. Unfortunately, over the course of the summer, we did lose our project leader to a prolonged FMLA, and that really hindered us in terms of being able to be as effective as we wanted in terms of getting all of our staff trained. So that was where we were at the end of the summer, was that we'd had some training done, but hadn't met our goal yet of 70%. Next, please. So as we faced the fall, we entered into the group project. We set a few goals for ourselves in the areas we wanted to focus in on. So we felt there was a need to standardize our patient education about perinatal health conditions. What were the tools that we wanted to use for teaching patients? We wanted to standardize our screening for perinatal mental health conditions. We did already have a practice of doing the Edinburgh prior to discharge for all of our patients, but we felt we could tune that up a bit and make sure we were consistent. We also felt there was a need to do staff training on perinatal mental health conditions. And then as part of this, we put together a more broad interdisciplinary committee, so including inpatient and outpatient representation. We did invite psychiatry to participate, which unfortunately they were not able to, case management. And we ideally, when we looked at stakeholders, also wanted to get some patient representative, but that proved to be a little challenging to do. That's something that's still on our wish list. Next, please. So patient education. So here's a beginning of a series of thank yous. I really want to thank the group at Milford, because they were the ones, when they presented with the mini collab, that clued us into PSI, Postpartum Support International. And so this, we learned more about that organization and all the resources it had, and decided that that was going to be the teaching tools that we would use for our patient education. So our goal was that by January 30th, 75% of our patients discharged from the mother-baby unit would have perinatal mental health conditions education documented, which would include giving them and going over with them the PSI handout. We also put up signs in all of the patients' rooms with a QR code to the PSI website to also use as part of our teaching. We created a staff bulletin board to educate people about this project and our goal, and to track our project. One of the challenges we faced as we did our auditing was just struggling with our EMR. We are on Meditech, and there were many different places for people to document this teaching. And so we did the audits. Connie gave individuals feedback as she did them to help us standardize where we were documenting. We did adjust our goal to April 30th with a goal of 85% of patients. And we actually reached 83% in April, which I consider a win. And we are going to continue to work on this. But I think we're very proud and very the staff has done an amazing job in terms of embracing this and doing this education. Next, please. The other thing we were inspired by Metro West and Lowell was the magnets. So we did want to create a tool for patients that would help them access perinatal mental health services after they went home. And one of the challenges we felt for us was that we do have patients from who speak a variety of languages, including some patients who are not able to read at all. So we did want to create something that we felt could be helpful for anyone, regardless of their literacy level. We wanted that to be something easy for them to find at home. So a magnet made sense. We could envision them putting it on the refrigerator where the patient could see it, their family could see it. And then we wanted to be cost effective and not too burdensome for the staff. So those were our thoughts as we went into our magnet project. Next, please. So this was the magnet we created, and it really was just a prototype. This was not the final finished product. This was our PDSA cycle. We wanted to try it out. And so you can see that the really emphasis is on the pictures, trying to put pictures on that would hopefully convey a mother who was stressed or sad feeling. We piloted it in English and Spanish. And so the QR codes on there link to the PSI website in that language. Thank you, Milford. Thank you, Lowell, for that idea. So this was what we were trying out as our PDSA, and we printed them fairly inexpensively from Vistaprint just to try them out. Next, please. So this was our timeline. In February, we're going to educate our unit coordinators and our staff about the magnets. We put them up on our bulletin board. We sent out emails. We have a communication book on the unit. We were going to talk about it on Tuddles, and we did all of that. And then we started giving the magnets out. And then our plan was several weeks later to start collecting feedback from patients when they went for their postpartum checks. Next, please. This was our process for giving out the magnets. Nothing's ever as simple as you think it's going to be, right? We're going to give out magnets. Well, how are we going to give out magnets? How are we going to remember to give out the magnets? So we involved our unit coordinators. When they would print, they typically print out the discharge summary and give it to the nurse at the time of discharge to give to the family. So we kept the magnets right by the UC, and the UC would give the RN the magnet at the same time that they gave them the discharge paperwork. And then the RN would give the magnet to the family while they were doing their discharge teaching around perinatal mental health, and would then document in Meditech that they had done this teaching. Next, please. And then for feedback, we were hoping that our OB offices could help us with that. So we created a very simple card with 5 questions on it. Did the patient remember getting a magnet? Did they know what the magnet was for? Did they actually put the magnet up on their fridge or somewhere? And did they actually access any of the information on the magnet? Did they call the phone number or use the QR code? And so our goal was to get at least 10 cards back to get some idea of how effective is this magnet? Do we need to tweak it? Next slide. And it was a resounding fail. There were 10 cards collected. None of the patients remembered receiving the magnets. And we actually had magnets in the office. So when the MA talked to the family, they could actually show them the magnet and say, do you remember this magnet here? And none of them remembered getting it. And then the MAs gave them the magnet at that point in time. And so, you know, the comments were there was too many things going on at the time, or they just didn't remember it being handed to them. And so what we took away from this is that maybe the time of discharge is not the best time to give away the magnet, because they are given so much information and so many papers at that time. And again, we consulted our colleagues at Lowell, who are so super helpful, and found out from them that they are giving them out at multiple points of care. And so our thought is the next phase may be to try giving them out. First, we'll make them a little bigger, a little more memorable, but then also try giving them out maybe in the OB offices late in pregnancy, but before they deliver. And then our feedback could be when they come to deliver, do they remember getting this magnet or not? And again, we could give out magnets then as well. And we could still give out magnets also when they come back for their 2-week or follow-up appointment. So that's the next thing we may try. Is we're not abandoning, we're adapting, and we're going to see if that works better. Next, please. Okay. So, and then the final thing we were tracking was screening for perinatal mental health conditions. So our goal was that by the end of January, 100% of our patients that were discharged from another baby unit would have a documented Edinburgh. And we, again, used our bulletin board, did some education around this. One of the things we found that partly through this webinar, which was super helpful, was just the realization that there are validated, translated Edinburghs out there. And as we dove into this more, and Connie actually put together a book for us with the Edinburgh in the various languages that are validated, we were surprised to find out that there's actually not a validated Edinburgh for our Haitian Creole patients, that culturally, the Edinburgh doesn't actually work very well in terms of sensitivity and specificity for this patient population. The RHS 15, which is designed for working with refugees populations, is felt to be a better tool. So this was very interesting for us to learn about. And so we continued with this, and for now we are continuing to use the Edinburgh, but one of our goals will be ultimately to incorporate the RHS 15 for those patients from whom there's not really a good Edinburgh. We did actually meet this goal. We had to adjust it a little bit by April 30th, but it actually turned out in February. We made our 100% goal. We had an ice cream party to celebrate. We let administration know how wonderful we were. And we're actually due for another ice cream party because our latest audits show we're still at 100%, which is awesome. Next, please. Big believer in ice cream. And then staff education. So we didn't actually have an aim statement per se for this, but our goal was for all of our staff and expanding this to include everyone who touches our perinatal patients. So inpatient, outpatient, NICU, mother-baby unit, L&D, both the licensed providers as well as non-licensed staff, for example, our unit clerks. And again, huge thank you to Lowell, because we were a little overwhelmed in terms of what to use for this education. And Lowell very generously shared their slide deck that they used for their education of the nursing staff, which was wonderful. We did tweak it a little bit. I actually ended up adding a few slides on trauma-informed care because we still wanted to get some training of that in as well. And our process was that there was a pre-test to give out, and then one of the other challenges we faced this year is with the change in terms of going from Steward to BMC, our platforms for nursing education were changed as well. And so, and the other big challenge we've had this year is just competing demands. There's been so many changes and JCO preparation, and that it's just been very challenging to add one more thing to people's plate. What we found worked for us was I actually ended up making a YouTube video of the slide deck with a voiceover, and that was very easy for people to access. The challenge with that is it's not through one of the more formal education platforms where it tracks for you, et cetera. So we were relying on self-reporting, that people had watched the video and then they have them do the post-test, and using the post-test as our way of seeing that people completed the training. So 60% of our staff, we had has done the pre-test, and 23% have completed the training. So this is still very much a work in progress. When we had people do the post-test, we did include some questions about the training itself. And one of the things that was really nice was the vast majority of people, almost everyone except two, said that they found the training very helpful. And the comments were really helpful too. Many people said this is so super important. We should be getting yearly competencies on this. We would really love more in-person training. So again, it was nice to see that that interest is there. And again, this was a very small sample size and not at all scientific. There was definitely still people who even after the training, when given a choice between being very comfortable, somewhat comfortable, and not comfortable talking about perinatal mental health with their patients, there was definitely still people who said somewhat and not very, but more people seemed to say very after the training. So that was nice to see as well. Next, please. So our next steps, obviously we're going to continue to work on our staff education. We would like to implement the GAD-7 anxiety screening tool, and our thought is that we will actually, when we give patients the Edinburgh, that we will also give them the GAD-7 at the same time. We would like to implement the RHS 15, particularly for our Haitian patients, but I think we're going to end up putting that off till the fall. Another big change coming from us is there's going to be a change in our EMR from Meditech to Epic, which will be great. But we felt that the RHS 15 might be easy to incorporate into Epic, and we can't really make any changes in Meditech anymore. So it's not like we can add a tool in there. We are working on revising our clinical practice guideline also to include the GAD-7 in that practice guideline for screening for perinatal mental health conditions. One of the other big struggles we've had is we have a awesome outpatient perinatal social worker. But we've been relying actually on social work interns to staff our inpatient unit. And so they come for a few months and then they're done. And during the summer, we don't have any. So we are posting and hoping to recruit an inpatient social worker. If anyone knows anyone they want to send our way, because that's a really key part of our screening and referral process. And then, as I said, we're also going to continue to refine the magnets. The one other thing I forgot to mention was that we did, Kara actually presented this project a few months ago in a hospital-wide safety fair. And what was really cool was that she had a lot of people coming up and talking to her and relating their own experiences, like people who work in security, people who worked in food services would come up and say, oh, my wife struggled with this, or, I struggled with this. And so one of the other things we're wondering about is, how can we do outreach for the employees in our institution? So we are hoping to work maybe with marketing or HR to think about how we can offer these same kinds of education for all of the staff that work here. Next, please. And this is just an example of an algorithm that we created that we're going to use as we do our, as we revise our guidelines. So including the GAD-7. So based on how the patient scores would trigger then a certain response. So if they scored if they scored 5 to 9 on the GAD or 10 to 12 on the Edinburgh, that would trigger a social work consult on the inpatient unit and a postpartum visit within 2 weeks. If they scored 10 or more, 10 or more on the GAD or 13 or more on the Edinburgh, that would be a social work consult, and we'd also notify the OB provider. And it would also trigger an email to our outpatient social worker, and she would reach out to that patient by phone within 2 working days to do a screening over the phone and schedule an appointment to see her. And then obviously if the patient answers to question 10 with any thoughts of self-harm, that actually triggers social work and a psychiatric consultation and assessment for risk for suicidality. So this is what we'll be incorporating into our upcoming guideline. Next, please. And so what we've learned along the way. So one of the things that we feel is a challenge for all of us is the equity piece of it. PSI, for example, great handouts, but only in certain languages. And we talked about, the need for a different screening tool, for example, for refugee populations. So this is something that we're continuing to see as a challenge, and we're hoping being part of BMC will actually help us with this, because we know that BMC has a great history of working with diverse populations, and we're hoping that we can learn from them and get more tools from them. Data collection has been challenging. Meditech, we have 2 different EMRs, Meditech inpatient, Athena outpatient. Hopefully Epic will solve that problem for us. Timing is everything. And, in retrospect, maybe this wasn't the year to take on a very ambitious project because, with all of the transitions and the turnover in leadership and, I think it's been challenging for our nurses in particular to engage in this project because there's just been so much uncertainty and so many changes going on. So, on one hand, you could say timing is everything and maybe this wasn't the time to do it. On the other hand, maybe you just have to do these things whether timing is good or not, because these things are important to do. There's definitely an importance of having the right stakeholders at the table. And as we talked about, ideally involving a patient voice at the table, which is why we love going to the webinars and hearing from patients sharing their experiences is so helpful to this work. And then the other thing is just the incredible benefit of participating in this collaborative network. We have learned so much from the other hospitals that have been so generous, and even the ones I didn't name, or all of them, like Beverly and MGH and BMC. I mean, we've learned something from every place, and we're really, really appreciative of that. So thank you, and thank you, Callie.
Thank you so much, Lisa. This has been wonderful. And before I turn it over to Tiffany, I just want to say thank you and congratulations on everything that you have been able to accomplish despite, the challenges that you named. I mean, that's no small thing to have taken this on at this point in time. But I think the second part of what you said is right. Some may have not have been the best time, but also any time is a good time to start this work because it truly is so important and you never know, when you might be able to make a difference. So the time is now. So congratulations. All right, I'll turn it over to Tiffany.
Well, and I also have to say, oh my goodness, like such an amazing body of work. And despite the various challenges that you expressed, you have really accomplished so much very thoughtfully. And I appreciate you sharing, the initiatives that you then had to maybe pivot on a little bit or think about differently, because that's, we all learn from that. When we were thinking about the Pearl for this session, and having, known what you were going to talk about and reviewing the slides, one of the things you mentioned, it was, hard to identify a training or to engage people in training. So I thought that Pearl would be sharing a training opportunity that really is available to everybody. We can go to the next slide. So, at UMass, we have what's called the Lifeline for Moms team, and we got funding from National Institute of Mental Health a couple of years ago now, really to create an eModule on the training of detection, assessment, treatment, and follow-up as it relates to perinatal mental health conditions. This was designed in collaboration with somebody expert in adult education, somebody expert in instructional design, and doing a sort of interactive media and online education. And so these eModules are available on ACOG and through their ACOG website. You do not need to be an ACOG member. Anybody can access them. And I'm trying to think if there's still CME. There historically has been CME associated with them. The application had just expired, but we were working to re-up that. And so these modules are available there. If we go to the next slide. They were really designed to be self-paced, case-based, very interactive. They were designed around these, 4 individuals, Julie, Sophia, Adele, and Olivia. And you walk through each of their experiences in what hopefully feels like, sort of a real practice environment around real patient scenarios and clinical situations. And so goes through the detection. We can go to the next slide. Uses, as I said, it's self-paced. Most people on average did the 4 modules in less than 2 hours. As we were developing them, we worked directly with OBGYN physicians, psychiatrists, midwives who gave a lot of feedback into the design of these modules. There are suggested resources throughout, so you can self-click through, you can go at the pace you want. When there's something that is, particularly appealing or interesting you could dive a little bit further on it. So for example, we've talked often about depression screening and anxiety screening. And also we know both in the patient safety bundle and ACOG's clinical practice guidelines, there's recommendations around bipolar disorder screening, especially in advance of prescribing. And so it speaks to the MDQ, which is the mood disorder questionnaire, and the CD, which is a composite international diagnostic interview, which, if you don't know what it is, you can sort of click on it, pull it up, you could print it, you could save it so that it's in your pocket for the next time you need to use it. But any of the resources that are referenced throughout the entirety of the modules are available fully. You can go to the next slide. And it is interactive. So it isn't hit play, there's a talking voice in the background and you can walk away and like the 2 hours will finish. There is some like gamification of it where you interact with, your definitions of things and pulling it in, or the different disease states or what have you. Next slide. And then there are some concepts for which like it's a little bit more complicated. And so we did a discrete number of voiceovers where either it was myself or Nancy Byatt sort of explained like, how do you in fact take that screener and translate it into symptoms and severity of symptoms? So Lisa, I saw your kind of stepped approach to if the screener was this score versus this score versus this score, right? So how does that translate into severity of symptoms and potentially disease? Because that directly should translate into what the approach of treatment, the treatment approach is. And so there are just a couple of, recorded audios, because those you do have to kind of sit through and listen as opposed to doing at your own self-pace. So we tried to be very parsimonious in selecting the things that needed a bit more of a deep dive and explanation. We can go to the next slide. And then there are some highlighted summaries, right? Like, so we go through these cases, we go through, kind of content in the context of these individuals to make them real. And then there are summary slides to kind of put it all together. Next slide. And then when you get to the end of the 4 modules, you've sort of like completed fully your exploration through how to detect, assess, treat, and do follow-up in each of the cases of Julie, Sophia, Adele, and Olivia. Next slide. And so that is available. It's available to everybody for free. It's something that you could, assign or recommend that people do. As I said, it could potentially even use it like in the context, like in a didactic mode, sort of use it for somebody to present and go through, although it really is designed as sort of an independent self-paced. As I said, you do not need to be a member of ACOG to access this. And so I asked Callie to do this as, to like go through, because I think whenever I log into ACOG at this point, I think it automatically puts me here. So I wanted to make sure that we had, step-by-step instructions on how to get here to hopefully avoid any frustration or like, questions around where do we get that? How do we get that? This is where and how you get it. As you mentioned, Lisa, in you having some pre-test, post-test, there is a pre-test, post-test in this also, so that people have some sense of the sort of hopefully level of knowledge and hopefully comfort that one attains as they do this. And additionally, as I said, you can download the resources, you can download content and have it there to look for later. And I believe that is the last slide. Happy to take any questions.
Thank you, Tiffany. Yeah, the modules were very easy for me to access once I just refreshed myself on my ACOG account. And yeah, you do not need to be even an OBGYN physician or staff member to create an account. So I was able to do it easily and went through the modules myself, and they are wonderful. So we are early in our agenda today, so I do open it up to any questions about either the ACOG modules or the BMC Brighton team's presentation. You got lots of love in the chat, Lisa. So again, feel free to raise your hand or put a question in the chat. I'll stop sharing so we can see everyone.
Callie, one of the things you had asked me about was communication with the pediatric provider.
Yeah.
And so I was curious because, I had emailed you back that I'm always struggle a little bit between the what is mother's protected health information versus what should go in the baby's record. Because whatever I put in the baby's record on a discharge summary, for example, anyone she puts on the birth certificate as the other parent has full access to that. And the child themselves, when they grow up, if they want to, could pull that record up. On the other hand, I know my pediatric colleagues always feel that it is important to know if, and they screen with an Edinburgh, throughout the first year that they see that patient. So I'm kind of curious what other people's thoughts are on this topic in terms of what and how to communicate any mental health condition that the mother may have to a pediatric provider.
Wondering if there's any, oh, Hannah, hands up. I don't know if that's an answer or another question.
So I mean, a possible answer, also maybe a question along with it, but I know it can vary from EMR to EMR, especially when things are kind of separated from outpatient to inpatient and things like that. I'm currently at Sturdy, so we are very fortunate. We have Cerner, but the really nice thing about Cerner, which I know most people don't have a lot to say nice about it, but the offices, including pediatricians' offices within our network, OB offices in the hospital, everything communicates. And what sometimes will be done is, instead of making it necessarily a part of the mom's or the baby's like medical record in like a flow sheet or a document or something, there's almost kind of like a face sheet or a home page where providers will kind of put notes in terms of just things to be like awareness type things that maybe might be a little too sensitive to have actually part of the medical record, but can be at least noted somewhere that is able to be seen by other providers without it be, if especially the patient is sensitive about having it, like you said, when it can be accessed in the future, whether it's by their partner or by the child. But maybe something of that note, if there's a way to put just like a note or a flag on like the patient's face sheet, if that doesn't translate to the medical record, if patients are hesitant about that.
Yeah. No, that's a really nice feature to have. And what I have sometimes done is just called the office and said, there's some stuff I want to tell you that I'm not putting in the record.
Yeah.
The other thing I have to say, I wonder about, I'm curious from my OB colleagues, is, when a woman goes to see her OB provider and she discloses things and she talks to her OB provider, is she aware that the pediatrician will have access to that record? Do we need to ask permission before I go looking through a mother's record? I look through it because I think it's part of my ability to take care of the baby, but again, wonder about that HIPAA, right to privacy.
Yeah, I do think, I wish we had like our compliance or like legal, somebody from compliance or legal on here. I do know, for example, with MCPAP for moms, they will ask the providers, to expressly ask the perinatal individual, like, is it okay if I call and share your information? It just sounds like you're moving to Epic. In Epic, the mother and child chart is actually linked at the time of delivery. And so there is some linkage there where you can kind of go back and forth between them, whether or not that is continuing into your ambulatory environment, or, like in our institution, we have prenatal practices, obstetric practices that are on Epic ambulatory, and so they can see everything, versus we have some private docs that aren't, and so they can't, and then it ends up being an express conversation. And then the same thing with the pediatrics offices or pediatricians offices. Some are on it, some aren't, and so there isn't necessarily that assumption of linking, at which point, like, it often is an express conversation, right? If the pediatricians are screening, in that year postpartum, which they should be, then they identify somebody who has a high score on the screener. They're often not the one addressing it, but then saying, we're going to call your obstetrician or your primary care, and then they'll, address it.
Thank you. That makes sense.
And Lisa, like I shared in our email conversation, we will be having a webinar in November around PMHC screening in the pediatric and NICU settings. And so I feel like this would be a really great question to bring to those presenters too, because I'm sure they've had to navigate that as well. So I'm excited to follow up on that.
Thank you. Yeah, because we have been wondering about the NICU too, because those mothers aren't going to pediatricians' offices. So should we be
Right.
screening, but
Yeah.
then they're not our patient anymore? So where does that get documented? So that'll be great to hear more about that. Thank you.
Yeah, and actually what our, so we'll have two speakers in November, one for the ped setting and one for NICU, and the NICU folks are at BMC, the main campus. So definitely an easy connection to make for you all. Wonderful. All right. Thank you for the question. I don't see any other questions in the chat right now. I'll give it a few more moments and also just open it up to the group. We have 10 minutes, so if you have a question or something you'd like feedback on your work and this bundle that you'd like to post to the group, please feel free to bring up anything that may be on your mind while we have the time. Maureen, I just saw you come on video. I don't know if that was
No,
because you
I've
have.
been trying to get off video the whole time, but I realized I was not saying yes to being recorded, so it refused to let me in.
Oh, I see.
Just a
Sorry
fun
about
fact
that.
for next time.
Yes.
Thanks.
Yeah, of course. Oh. Well, if anyone's still thinking of a question or comment, I can just preview our webinar for next month in July. We're excited to have two members from the Penguin Perinatal Opioid Project leadership team come to share about the toolkits that they've developed for around SUD and OUD care for maternal and neonatal populations. So we've talked throughout this series about, the overlap, between substance and opioid use with mental health conditions. And so we wanted to have a webinar dedicated to that. So we're excited to share those toolkits with you all and those resources. And then MCPAP will also be back to talk about their SUD specific resources. So and that will be recorded in case anyone happens to be out on vacation on July 15th. So we're excited to welcome them back. The August webinar is a little bit up in the air. We're trying to secure a team presentation, waiting to hear about vacation schedules. So we'll keep you all posted on that one. And then yeah, we're going to finalize the fall webinar schedule with our work group actually just following this webinar. And so we'll be excited to share more about the fall webinars very soon. So, all right. I'm not. Claps from Katie. Thank you. All right. I'm not seeing anything else. So Tiffany or Lisa, any final thoughts for today's webinar?
Well, thank you, Tiffany, because I'm very excited about those modules. I think they will definitely be appealing for our providers. So thank you.
Well, and thank you for all you're doing. I think you demonstrated what a mighty team can do with persistence, regardless of timing. And you have been certainly going through a time of change. So it really was inspirational, and not just, you didn't just attack one part of the bundle, you've multiple parts of the bundle. So doing really tremendous work. Thank you.
Absolutely. Great presentations. All right, wonderful. Well, thank you all so much for joining, and we look forward to seeing you on July 15th again for those SUD-focused presentations from some of our partners. Thank you, everybody. Hope you stay cool with the intense heat that we're about to get over the next week, and feel free to reach out anytime with questions.
Thank you.
Thanks all. Thank you, Lisa and Carla.